got one, I got the other one.
Okay, that one was stuffed back in there. Thank you.
Do you want a pillowcase?
That would also be a good idea. Or sometimes I end up just covering up the pillow, but that's better. We probably do want a second.
Oh, no. Hey.
Do you want to do questions first?
Yes, I was just wondering, my recording was having an issue, and okay. Let me write it.
So, I see patients with the rheumatology fellows over in asthma and allergy, and because of this, we're very strict, and my students actually about being sure that the patient sees you use the Purell, okay? And I will tell you that one of my students a couple years ago Purelled outside the door and walked in with it and failed his neurology exam.
Oh, my goodness.
Was that the neurology clerkship?
Clerkship.
For a while, they had that as a major portion of their assessment.
Everything else
They've
was
adjusted
perfect.
a little bit.
I mean, he did it, but you know, it was fine. But anyway,
Yeah.
so in asthma and allergy, the door is here, the patient is here, you wanna come in and say, hi, I'm Dr. Ziminski, the Purell is here. So you have to walk back and forth, just,
Oh.
not all the rooms, but many of them.
So, but are you supposed to actually introduce yourself before you Purell?
No.
You touch them, you're supposed to, so
You're
you have to
supposed to
talk
Purell
and
first,
go.
so you have to walk across, say, hi, I'll be right back.
Yeah.
This is like in the actual patient room.
Yeah.
Oh,
With real
at least
patients.
here, we usually have the patients over here first, and they have a chance to go to the sleeping
Yeah.
Purell
Exactly.
first.
Or sometimes they use the soap, but we won't go
But
there.
that's only in standardized situations.
That's okay. Okay.
So only a couple of questions really, and some of these were from Momo, just to kind of, you know, in case these questions come up from the students. So with range of motions in the hips, we have the leg roll, and then also what we just sort of casually call the flagpole maneuver.
Oh, okay, I like that.
I can read it out,
I
but
like
I
it.
just, you know,
That's fine.
for our shorthand. And so the two questions are, one, does it, because, you know, it's in a particular order the way it's written here, but does it really matter what order they actually do it in? Okay, all right, so I didn't think it did, but that's good
As
to know.
long as they do it.
As long as they do both of those.
Right.
And then the other question is, what are those two different maneuvers testing? I believe they are testing different things, but in case this comes
Well,
as a question, what are they
so-
testing?
So the log roll is just doing internal external rotation, right? The flagpole is doing hip flexion.
Okay.
And also you get knee flexion extension with the same maneuver, which we can also do separately.
So leg roll and then do
Right.
flexion and then 90-degree angle and internal external
Right.
rotation. So my question was this internal external rotation to this.
Oh,
This
it-
one?
Yeah, oh, so that part is, thank you. It's sort of the same thing.
Okay, so it is.
But so if you think about the hip, the ball and socket, if you're just rolling the leg, it's in one position, right, with all the anatomy of the head of the femur. But if you have the leg up and you're doing it, it gives you a little bit more, whether there might be some other limitations on the bony structure of the hip joint. It's just this, I don't know that I've ever noticed a big difference, but.
No,
But just things that
that's
you could
great.
find in one maneuver that you
Right.
wouldn't find in the other
Right.
maneuver.
And then if you, I know Patrick's test is now optional, but if you were gonna do it, that'd be kind of where you would do it,
Exactly,
it would fit in
exactly,
there.
yeah.
Mhm.
So, you know, and when I was writing up this script, however many years ago, I sort of do these things without thinking. So to actually put what order I do and how I do it was
Right, yeah.
Right, it's like giving somebody driving directions
Yeah.
someplace, you just drive all the
Yeah,
time.
you just drive, I don't know.
Yeah, you turn where there's that flagpole.
Yeah.
The other question, is just for more clarification, I think we have a few notes. So under 3, where we inspect and palpate the shoulders, where we're, palpating the acromion process and, acromion clavicular joint.
Right.
I know one of the things you're looking for there is whether there's any painful areas or tenderness, and also you had mentioned before that you're also checking for warmth. Is there anything else you're looking for when you're doing that? Okay.
I mean, you may sometimes, well, I say you don't know that, I can think of something. Somebody may have a big swollen shoulder and you wouldn't see your anatomy, so you're sort of looking for, but most people don't
Yeah,
have a prominent swelling.
if they just had an injury or something.
Yeah.
All right. And I
But
think
you would see that when you're looking at symmetry, someone would be.
that's true, and that's something I had a note, as a little note from last year up under the core principles that, it says all
Right.
these things that you're observing, you're also observing for symmetry, which I think I had just added in as a training note for the PETAs, just to mention. And then just to briefly touch on those, just to make sure my little training notes from last year are still, what we're looking at. One small thing is under number 1 with the hands and wrists. It says thumbs singular, but I think we want thumbs plural because we're palpating the MCP joints on both hands. So it would be thumbs.
Right.
And a little note that I had when you're under shoulders, when you're observing the posterior muscles, that you're checking that the musculature around the shoulders is intact. Okay, anything else that you would add to that? Okay. And then also that you're noting whether there's warmth, which we discussed. And I didn't have that many notes from previous times, because these are such well-written materials.
Finally.
Right.
We've gone over and over it.
Oh, and this is just like a little extra training note for the PETA. So under 11, lumbosacral spine, inspect and palpate, I just had a note that, because we have the patient lying down and also standing, that can be helpful to let the patient sit for a second after lying down just to regain equilibrium before standing. And then next down on 12 with the lumbosacral spine range of motion. Just to, I think we all sort of know this, but just to have it clarified in writing that the reason you're putting your hands on the patient's hips on each side is to prevent the whole torso from twisting. Okay. Which I think we sort of know, but every once in a while you'll see students who, if they forget the reason for doing things, they just put their hands in places in ways that are confusing.
Joe, I haven't.
And I think that's it.
Okay. Do we have it written in there that that's why we're doing that, or?
In the syllabus, I don't think so.
Because I always tell people that that's why we're doing it.
Right, and that's why I added it as a training note, because I thought, well, let's just go ahead and have that in writing. In the syllabus, I think,
Maybe I should add
let me just compare it.
number.
I just got it here, a second.
Well, it says while you stabilize the pelvis by placing your hands, so that suggests.
I guess it sort of
no movement.
implies, but
It's
it doesn't.
implied that, yeah,
Yeah.
that's true. And so maybe my note was just to add those little extra layman's terms.
Yeah.
Yeah.
Make
Stabilizing
it very
is to
clear.
prevent it from twisting.
Because
Yeah,
what I
that's
always
a
end
good
up
idea.
doing is I have the person with the hip stabilized, and then I say what happens if you don't. If I ask you just to twist, and I don't have your hip stabilized, then you see I'm turning the whole torso. So I always tell them that.
Right, yeah, and I think it's in there. I think the only reason I added it was sometimes people can interpret stabilize to mean you're stabilizing something else.
Yeah.
You never know. We have a lot of people doing this, and I see a lot of different interpretations.
Gotcha.
So. It's nice to be clear. So, and I think those were the only little notes I had. Did anybody else have any other thoughts or questions about the materials? No? Then what I would like to do, like we usually do, if I can have you do a demonstration. Kristen has agreed to, I know it's usually helpful for you to have somebody just read from the
Yes,
materials to
because
remember the order in which we've written it.
And
And I do things a little bit differently
And
sometimes.
if you get tired of me reading, Momo can read half of it. 'Cause she's also
you
trained.
Well, Tyler did volunteer, he's
I'm
new to
good,
me,
I'm
so. All right, and then what I will do is I was gonna monitor the cameras, I'll pop in if I need to, but this exam hasn't changed much from year to year, so we don't usually have too many pop-ins necessary.
Right, good. Okay.
Okay,
We're good to go.
Okay.
the musculoskeletal exam maneuvers. This is time to complete 7 to 8 minutes when proficient. The core principles are inspection, palpation, and range of motion. Number 1, inspection. As you observe extremities and joints, compare with the contralateral side. Do you notice any joint deformity? Do both sides appear equal in size and contour? Is redness and swelling or swelling present overlying the joint? Number 2, palpation. As you palpate, notice, are there areas of tenderness? Do the joints feel warm? Is an effusion present? Number 3, range of motion. As you test range of motion, notice, is it full or limited? Is pain evoked with motion? Do you want me to read all of this?
Oh, that's pretty good. You're a good reader.
Next, position, draping, and disrobing. Thank you. As you give specific attention to bones, joints, and muscles, the body surface must be exposed and viewed with good lighting. Position the patient to provide the greatest stability to the joints. Position the extremities uniformly as you examine and look for asymmetry. The upper extremity exam. Rationale.
Oh, don't read the rationale,
Okay,
that's fine.
okay.
We don't need the rationale.
We can read that. Talk amongst yourselves. Hands and wrists, inspect and palpate. Inspect for symmetry, swelling, deformity, or erythema. Then palpate for tenderness, bogginess, or bony enlargement. Number 2A, palpate the DIP and PIP joints of the thumbs and index fingers using a 4-point approach. Palpate the finger at the DIP, then the PIP, using your thumb and index finger on each side and on top and below.
So, let me pause for a second. So I usually will take the patient's hands and sort of hold them for a second and compare side to side. And then I'll rest one down and I'll support the patient's hand sort of from somewhere up the bottom. And this 4-point approach to me makes a great deal of sense, but sometimes it's hard to explain. So I hold the joint north-south and then palpate it east-west. And if you sort of bounce back and forth between top and bottom, side to side, if there's anything under there that shouldn't be there, you'll feel it. So if it's bony or if there's some soft tissue swelling, you'll feel the difference. So we start at the DIP, the PIP, and then the MCP. And I forget how it's written there because I don't think you read it yet. But then if you flex the finger down, it opens up the joint space at the MCP, and you can feel the difference between if the finger is fully extended or if it's flexed down, it opens up the joint space. So we do DP, MCP, and then I guess I usually march back up the other way, a couple of fingers, so you're going up and down. And then you want to not forget the thumb, both sides, although I guess I'm not doing 4 points there.
And then the wrist.
And then, but I think we changed it so they only have to do a couple of fingers. They don't do all 10 fingers in both hands. Or did we change it back? Maybe that's for the final assessment. And
I believe it was for
for the final
yes.
assessment. So they should practice, and you can go up and down. Or they can go, either way, as long as they get all the sights. And then the wrist, again, you support the hand, the arm below, and then palpate a little bit over the dorsum of the wrist. And the ulnar stylo. I think that's how we put it.
And just one general note, especially for some of the new people and for anybody on the video, if we talk about anything that's on the final assessment, that is not
What
to be
we're
mentioned
doing
in
here.
teaching. So
Right.
because Rob does not want us to teach to the
Right.
test. Okay.
Exactly.
Just to make sure, it's okay for us to know,
I
but we just
forgot
don't wanna
what it
teach
was.
it to the
Right,
students.
no, I understand. Right, okay.
Mhm.
If there's a fogginess
Mhm.
in the wrist, would
Mhm.
you feel it on the dorsum
Yeah.
side?
Yeah, usually. And then sometimes we would, if we worried or somebody has carpal tunnel, we'd go to this side and palpate, but usually you feel it on the dorsum or around the, or the ulnar styloid is not the prominent bone that it should be. It's sort of spongy or disappears.
Here?
Yeah.
Wow.
And then, number 2, hands and wrists range of motion. Ask the patient to do a finger curl, fingertips to palmar crease. Make a fist with each hand, thumb across the knuckles in the front.
Oh.
Yes.
I did it backwards.
Extend and spread the fingers. For the wrists, flex and extend the wrists. With palms down, turn the hands or fists laterally and medially, ulnar and radial deviation.
And I usually show somebody what I want them to do. So if this fingertip to palmar crease isn't a fist, it's a it tells you whether there's anything really at the DIPs or PIPs, it's a little bit different.
Do you
Like if
do
they
that
can't,
too?
they have, they
It
can't,
sort of
they
gets
have
in
a
the way.
hand that won't, a finger that won't bend or.
Right.
So just the fingers and
Just the finger, the thumb sort of gets in the way, sort of sticks out there.
Okay. Then, shoulders, inspect and palpate. Inspect the shoulders and shoulder girdle anteriorly, noting any swelling, deformity, abnormal positioning, or muscular atrophy.
So I'm gonna ask the patient if I can untie and let this slide down a little bit, whoops, a little slack, over shoulders, there we go. And then you want to sort of take a look to see whether there's, you know, there's a tilt or whether there's asymmetry or whether there's something going along. And then, so we look from the front, everything looks fine, and we look from the back to see that everything looks symmetric, there's no bony prominence, there's no bulge, there's no apparent swelling. And then we would lay hands over it to see whether it feels warm or not.
Okay, inspect the scapulae and related muscles posteriorly. Ask the patient to indicate any painful areas. Palpate the acromion process and the acromioclavicular joint, and if applicable, and as applicable, any painful areas that they might tell you about,
So,
gently.
yeah, so I always ask the person if anything hurts and I come to that spot or that side last, otherwise you don't get to finish. So along here, you would start palpating along the clavicle and you come to the tip of the clavicle, and the acromion is out here at the tip, and the acromioclavicular joint is there.
And if you can't find it, you can ask them to move their,
Move a little bit, although, yeah,
you can feel it.
and then you can feel it moving.
It's like a shoulder roll, or?
So it's just moving the shoulder out a little, moving the arm out a little bit.
Mhm.
We used to have them dig for the coracoid, but we stopped doing that because it's too hard to find.
Okay, where am I? Okay, now, shoulders range of motion. Ask the patient to shrug the shoulders
So can you shrug your shoulders up?
and expect to see them raised symmetrically. Raise both arms laterally and straight up overhead. Expect abduction of 180 degrees. Place both hands behind the neck with elbows out to the side.
That just means so
Expect-
you're not doing this.
Yeah.
Pretty much,
Expect external rotation of 90 degrees. Place both arms
Behind you a little bit.
behind the small of the back. Expect internal rotation of 90 degrees.
Right, relax. So, sometimes people have asked if, you know, do they have to be up here? The idea is to sort of get to the middle of the low back.
Mhm.
The other way, I teach it in small group, so this gives you sort of a general range. If I'm examining somebody, what I often will do is I will have done hands and wrist, we ignore the elbow, but I come up to shoulder and I'll do it this way. Okay?
Unless somebody says their elbow hurts.
Right.
And then what do you do?
And then I examine, well, I always examine the elbow, but anyway. But then I teach people, if we're doing this, to rest your hand on the shoulder while you're lifting it up this way, because if somebody has trouble at the shoulder, put your hand up here. If I can do this, that's good, but if I have sort of a frozen shoulder or limited, I'm gonna get this far and then I'm gonna do this. And you'll feel the whole shoulder
Move up.
mechanism move, yeah.
Mhm.
And it's also, so sometimes you get that sense if somebody's doing this, they'll kind of go this way and they'll reach it up and that'll give you a clue that there's something wrong.
Mhm.
Doesn't tell you why, but it's a start.
Next, 5A, hips straight, inspect and palpate. Optional practice with PETAs omit in student peer practice. Prior to inspecting, ask permission to inspect the hip joints in the supine position. Begin by draping the hand over the groin area to preserve modesty. Inspect hips anteriorly. Use the major landmarks of the iliac crest and the greater trochanter of the femur, noting any asymmetry in the iliac crest height.
So,
Palpate over the greater trochanter to evaluate for trochanteric bursitis.
so this is what we don't do with the students. But the idea is to get the drape so that everything sensitive is covered. And then you can still you can feel along the femur to the trochanteric area. And you would, what was the first part that it said?
The
Inspect?
first part, yeah,
So
is
that's aligned?
inspect the hip joints in the supine position, and then inspect the hips anteriorly, and look for the iliac crest.
So you're just looking along here and feeling to see where the iliac crest would be.
And then the greater trochanter of the femur,
Is out laterally.
and, wait a minute. We were taught, and I don't see it here, maybe it's, that you could, if you couldn't find the greater trochanter of the femur, that you could ask them to turn to one side where their hip is up, and you could,
Yeah.
it's like the highest
You can roll a
point.
little bit, yeah. That's right, yeah. Thank you. By the
And
way, I
as-
mean to hurt if I hear it.
Ask the
anything hurts,
patient
let
to
me know.
lie
Sure.
or remain in the supine position with legs extended and relaxed. Gently roll each leg for assessing internal and external rotation at the hip.
And I probably usually tell patients, I'm gonna put my hands here and roll your legs. So we're telling the patients at each of these steps what we're doing.
Right.
So I'm just gonna roll your leg, tell me if it hurts, and then I'm gonna,
So on the internal external
Mhm.
rotation, especially sort of in this position, what is the range of motion you're looking for? Like when does it become pathological or?
you should be able to get a little bit beyond the midline
Mhm.
and out 60 degrees or so.
Okay.
But, you'll be able to tell if it's quite limited.
Sure.
And then,
And then you test the hip flexion by bringing the knee up toward
I'm
the
gonna bend
chest
your
as far
knee.
as it will go, while keeping the other leg straight.
we're at 90 degrees, and then we do internal and external again. Does that feel any different?
This says expect
bit,
hip
yeah.
flexion of 120 degrees.
Yeah.
And then bring hip and knee joints back out to 90 degrees with the thigh perpendicular,
So,
holding the shin parallel to the exam table.
so we got as far as here,
Mm-hmm.
and then we come back to 90,
Mhm.
and then we do this, back and forth. And we do one side.
And that
the
says
other.
expect internal rotation of about 40 degrees.
I need to let your leg go. Okay.
Inspect the knees, noting alignment and any deformity, whether they're bow-legged, which is genu varum, knock-kneed, genu valgum, or flexion contracture and inability to extend fully.
So sometimes I'd have people stand at the foot of the table and just rolls so you see whether the knees are lined up a little bit, or somebody's lying on the table. You can sometimes tell if they're really knock-kneed or really bow-legged. And then, I guess that was inspect.
Yeah, then note the atrophy of the quadriceps muscles, any
Mhm.
atrophy.
Mm-hmm.
Look for loss of the normal hollows around the patella.
So here. At this point, I typically would just relax. Hardest thing to do on command. I would be holding the leg myself in the medial position. So, and if, tighten up again, and you see that the landmarks change.
Right.
So you wanna have the patient relaxed,
Yeah.
hold the leg, and then then you do your looking for fusion.
That's kind of worth mentioning. I don't
To
see it
relax.
written anywhere here, but that's good. Okay, and then palpate these areas, noting temperature, elevation, swelling or tenderness in the popliteal space.
So so at this point, you don't have to have the leg in that medial position. So you can just palpate the popliteal space, and you get the posterior tibial tendons
And the tibiofemoral joint space,
which is right along the joint line. And then you come anteriorly to the patella, which wiggles. The infrapatellar fat pad below the patella, and there's a suprapatellar pouch.
Mhm. And then knees, range of
have any?
motion, you've already done the flexion. Straighten the knee and stretch it, expect full extension with up to 15 degrees of hyperextension.
Right, so,
We can always work that in right after you already were bringing it down,
Yeah.
so it's flow of motion.
yeah, so it's hard to write,
Yeah, yeah.
but, so I typically roll the leg, bring the hip, so roll the leg for the hip, bring this up, da-da-da-da-da, come back out, and while you're there,
That, yeah,
you test the
hyperextension.
hyperextension. Now, for the students, they need to sort of be thinking joint by joint, which is why we do it
Right,
backwards. But I point out to them that when they're doing the hip flexion, they're also getting the knee range, unless they're doing it this way, which is more of a straight leg raise, which is
Right.
different.
Mhm.
And we're typically with a straight leg, you don't get as much flexion, because everybody's hamstrings are
Yeah.
Yeah.
so,
Okay, and is that straight leg in there?
no.
Okay. All right. Number 9, cervical spine, inspect and palpate. Evaluate for an abnormal curvature of the cervical spine. Patient sitting.
Do we,
Sorry. Wait, I don't know if I missed it. Did you demonstrate the bulge sign?
I think we skipped.
Oh, no, we skipped
Oh,
the
did
bulge.
we?
I was-
I'm sorry, I'm
I
so
was-
sorry.
Yes, I was doing it, but we
That's
didn't
my
talk
place.
about it.
Thank you, thank
Let's,
you.
that means you're right back.
Keep me on track.
I was doing it naturally, but we weren't talking about it.
Assess for effusion by the bulge sign on the knee.
So this is when you need to have the knee, at least I think it's best to have the leg midline. And then you sort of, you're looking for the depressions or the dimples on both sides of the patella, so you would not expect to be able to demonstrate an effusion here. But then, it's a funny word, you just push, you milk, if there's any potential fluid, you use this upward motion. I tend to do it with the fingertips, it may say the palm or the palm of your hand, but you just sort of,
For the camera view, I'm just gonna move this sheet slightly, Eric, sorry. Thank you.
you just sort of maneuver a little bit up this way, and then you come down the other side. So it's up and then down. If there's fluid, when you're doing this upward maneuver, it'll push it up north of the patella, and then you come down the other side, and that lets it fill out in here. And if there's fluid, this dimple fills out.
So I noticed that some students, milk it
Mhm.
medial,
Mhm.
and then instead of coming down, sometimes they kind of like push,
They can do that too.
like.
That's the next thing I was gonna say. Or they go up this way and then sort of pop here.
Yeah,
That's okay too.
okay.
You don't have any fusion. Did we get it?
Yep.
At least on the right leg.
At least on the- Just-
Yeah, you gotta check
There's
that.
not one on the left. Good, okay. Now let's you sit up again.
Just a bulge sign.
Bulge sign!
Charlie has a bulge sign.
Yeah, Charlie does.
Maybe we'll save that for the end.
It's okay.
We'll show it to you too. Okay, so we're going to evaluate for abnormal.
I do too sometimes, but.
Let's go ahead and get through the rest of it, and if anybody needs to see Charlie's bulge sign later.
Okay.
See if we can tip him a little bit.
Hey, Charlie.
Evaluate for abnormal curvature of the cervical spine. We're inspecting and palpating cervical spine.
So the cervical spine should be a reverse C. Little lordosis, right? The thoracic spine has a kyphosis. The lumbar spine has a lordosis again. So it's in, out, in. And then we want to palpate along the cervical spine. You can do it with thumbs, although if you have the person sitting this way on the table, it's a little hard to reach around, so it's also okay just to march with fingertips down the spine. And it's not written this way, but I typically, if I'm here, I usually just keep going down the spine.
Yeah.
all the way down when I'm there.
To.
Did you already do that?
Down to the
The
lumbar
lumbar
spine,
spine.
do the whole thing along the way. But it's also okay, it's better for them to think about functionally,
Compartmentalizing.
we're doing the cervical spine now, so I'm gonna palpate here, I'm gonna palpate a little bit on the sides to see if there's muscle tenderness, which there isn't, and there's not any asymmetry.
And then you're gonna ask the patient, we're gonna look at range of motion. You can ask the patient to touch chin to chest, flexion, expect 45 degrees. And bend the head back.
Look up at the ceiling,
Expect hyperextension of 45.
straighten up again, tell me if it hurts anywhere while we're doing this.
Bend the head to each side.
Is it bend or
Shoulders.
tilt?
Ear,
That's the
ear to
bend,
each,
oh, ear, okay, ear,
ear to
okay,
each shoulder.
okay.
Expect 40 degrees. Turn the head side to side,
Lateral
chin to
rotation.
shoulder, rotation.
Good,
70 degrees there.
good, normal range.
Then the lumbosacral spine, inspect and palpate. Ask the patient to stand, view the spine from the back and the side. Observe the patient's ability to stand erect, the symmetry of their body parts and the alignment of the extremities. Note any lordosis, kyphosis, or scoliosis.
So I usually untie down here, but then keep things held together. And again, you see the normal lordosis, and you can palpate over the spinous processes, and there's nothing that's tender side to side. In the middle or side to side. Okay.
Then ask the patient to bend forward at the waist and touch the toes. Expect 75 to 90 degrees.
And you notice that the lordosis flattens out.
And
then
that's where you
straightens
would see scoliosis pretty clearly too.
Yes, I mean, sometimes you can see it if when the person's standing, you'll see a curvature, but sometimes it's in the flexion that the scoliosis comes out. Thank you for reminding me of that.
I have it, so I
Ah.
point it out to him every time.
But you notice that the lordosis flattens out, which is what you want. There are disorders in which this is lost, the spine is stiff, and then it doesn't change with flexion.
Okay. Then you're gonna bend back at the waist as far as possible. Expect hyperextension of 30 degrees.
Good, good, good.
Bend to each side as far as possible.
Perfect,
35 degrees bilaterally.
perfect.
Rotate and swing the upper trunk from the waist forward and back while you stabilize.
Ah, see,
That's
you're
a
cheating.
forward
You know
and back. Forward and back
You know
is
you're not
kinda-
supposed to do that. It should be side to side.
Yeah. Side to side, yeah.
So, yeah,
So you stabilize high up at the waist
Well-
rather than down at the hips,
no, I
or?
stabilize at the hips.
Okay.
I reached in the wrong place, yeah. Okay, so you stabilize sort of over the iliac crest or in that region so that you're not turning the whole torso.
So it's a typo there to say forward and back, it should say side to side.
Yeah.
Okay. Alrighty, and then we have the optional advanced skills, which are the provocative tests.
Okay.
Oh, did we do we did the back-to-back,
We did
but what we
forward back.
didn't mention is holding them so that they know that you're kind
Oh,
of there for
when they're
stabilization.
tilting back, yeah.
Yeah. Okay, advanced skills, optional. Called the provocative tests. Evaluating hand and wrist pain. Tinel's sign, with your finger percuss lightly over the course of the median nerve of the carpal tunnel, in the carpal tunnel, under the flexor retinaculum and volar carpal ligament,
So,
Tingling, oh, go ahead.
go ahead.
Tingling or electric sensations in the distribution of the median nerve, palmar surface of the thumb, and the index, middle, and part of the ring fingers, if the sign is positive, suggesting carpal tunnel.
So I support the hand, and sometimes I extend it a little bit, and then you just tap over here. And people would feel something going up or down a little bit if they have a positive Tinel's, and that should be done on both sides too.
Okay. Then there's Phelan's test, which is holding the patient's wrists in acute flexion for 60 seconds. And you can do it either way,
You can do it, or the
up
prayer.
or down.
This
And
is acute extension.
Oh, with elbows out?
Oh, it doesn't.
Doesn't matter
This,
as long
this
as
Well-
needs to be 90
Sure.
degrees.
So it has to be to get the
Oh.
wrist.
hands
Has to be get to the
together,
wrist to 90 degrees.
yeah,
I see.
right angles. If numbness and tingling develop
Unless I come
in
right
60
down.
seconds,
Mm.
Yeah.
that's a
Either
positive sign
reflection
for
or
carpal
extension.
tunnel syndrome.
Yeah, so people who have rheumatoid arthritis, for instance, will lose range at wrists, and they won't be able to get to 90 degrees, they'll only get this far. Well, then you can't test by the prayer or this
You have
way.
to do this one.
You have to do this, which is variably accurate, but
Okay.
it's a clue.
Then there's Finkelstein's test. Ask the patient to make a fist with the thumb inside the curled fingers and then gently deviate the wrist toward the ulnar side. If the pain increases with this maneuver, it's positive and indicates de Quervain's tenosynovitis.
I do have tension here, like it's a stretch.
Yeah, so if somebody is complaining of wrist pain, and I'm gonna do this test.
So
I-
they're already positive for.
So there's a clue, so I always start with the other side. And I show them I want them to do this, I don't want them to fist, I want this, cause this is already stretching this tendon a little bit. So you close it up, make a fist, and then I support this, relax, and then I just stretch this tendon a little bit. And if you do that, you do feel a little tension and a pull. So I want the person to know what it feels like when it's normal, assuming they don't have bilateral tendonitis. And then I go to the other side and it's clearly different. You feel a sharper and ouch, no, I can't do this. So sometimes if it's real, they can't even complete this positioning maneuver.
So it should be done passively, not,
It's done passively.
okay.
Which I think I was getting active, which also increased the stretch I felt.
Yeah, exactly.
I think I have that, but I feel that right.
Yeah,
I had someone test it once.
so you feel it along here.
Not until you go farther down, then I start to feel it.
So you have a little.
Yeah.
I've had two
Right.
students that actually almost screamed.
Oh,
They had it severely
And they
and
didn't
were
know.
so surprised.
sometimes the other thing that you find when you're doing range of motion or this is hyperextensibility. With people, especially the kids, they're so young, they're all very flexible and they can, do this
Yeah,
and all the way back here. And that, or hyperextended elbows and wrists, they often have joint pain. It doesn't set them up for anything nasty, I'm always reassuring them. But they do go beyond the normal range, which is fine.
Then moving on to evaluating shoulder pain. Jurgensen's sign, with the patient's arm at the side, elbow flexed at 90 degrees with forearm pronated, palm down. Ask the patient to supinate the forearm against your resistance.
So,
This maneuver will cause pain
right.
in the area of the long head of the biceps in people with bicipital tendonitis.
Okay, so arm is at the side, you're supporting the arm, and you want, with the arm pronated, and you want them to turn this way against your hand.
Against this hand.
Well, just turn.
Okay.
Actually, I should probably hold it better this way. No, turn. Then you feel it up
The
through here.
pain would be up.
Yeah.
The empty the can test. Do you want them to stay seated through all of these, or should they?
Yeah,
just-
no, they can
Okay.
sit, it's easier.
Empty the can
Not supposed
test.
to be a workout.
Ask the patient to position the outstretched arm at 90 degrees
Be careful.
while maximally internally rotating the glenohumeral joint so the thumb is pointed downward. Then
So I have a
ask the
pop in
patient,
there,
Ah,
but.
oh, you're good, we just.
ask the patient to resist attempts to push down the arm.
That was it.
Oh,
So-
well.
Yeah, so turn this way, and then,
okay.
yeah.
Okay,
Oh.
so you turn it like you have a can in your hand and
Right.
empty it, and
And then you
then,
try to push down.
yeah. Then the painful arc test, which would indicate rotator cuff tendonitis. The key to finding the pain is in the rotator cuff on active abduction, usually between 60 and 120 degrees and sometimes when lowering the arm.
So
You're going
you go this
all the way
way,
up.
and do I have pain when I'm doing this? Ay, 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 ay.
About,
about through here.
Yeah.
And then sometimes I get to here and keep going. There's another one, isn't there? And I push in.
drop arm test.
Yeah.
Ask
Oh,
the
I'm
patient to
trying to hold
abduct
it
the
here.
arm straight out to 90 degrees
No, it's 90
and then
degrees.
slowly lower it to the side.
So, and then sometimes you can't if there's a tear.
Oh, right.
Okay, I can get this far and then I lose it.
Yeah,
Or I'm trying to go down slowly enough, I just touch your arm, it collapses.
so if you have a rotator cuff tear, the arm will just drop, you won't be able to
Right.
control it.
Could you point out the rotator cuff?
Oh, it's this
Where-
whole, it's a whole collection of muscles up
Right
through
there,
here.
okay.
Yeah,
And that way you can also tap the arm a little bit.
yes,
Mhm.
yes. I was trying to mumble that, but you know, good.
So now, looks like we lay back down, we're gonna do the straight leg maneuver. Which if we were gonna do it, we would have done it
We
when we
would
were.
have done it before.
If it were necessary.
This is
Or
when
if-
somebody you think has maybe disc issues and they're complaining of low back pain or maybe shooting pain down the leg, this is when you would do that. It's not something you would do in
Straight
all
leg maneuver.
circumstances.
This is a provocative test for a patient complaining of low back pain with radiation into the leg,
Just wanted to-
sciatica. I'm reiterating.
I forgot it was there.
With the patient lying supine on the examination table, raise slowly the patient's relaxed and straightened leg, flexing at the hip until the patient feels pain, and then dorsiflex the foot.
So is this passive or active?
This is passive.
Okay.
And sometimes people want to help, but it's passive. So I just want to lift your leg, and
So
I'm
they're
do it slowly.
relaxed.
But you tell me if it hurts.
If there, I'm getting the stretch behind the knee.
Ah. If I do that.
Yeah, it gets-
Sorry about that. Okay.
Record the degree of elevation at which
45.
the pain occurs, the quality and distribution of the pain, and the effects of dorsiflexion.
There, I've
Same
got
thing,
the
back to
stretch
here.
and the tendons here behind the knee.
Okay. Although that's more hamstring.
Are we supposed to dorsiflex the
Okay.
foot too?
Yeah, I did it on this side of bothered, so I didn't do it on this side.
Ah,
Straight leg that suggests disc should give pain up to the back as well as sort of shooting behind the knee. A lot of people get attacked behind the knee, yeah.
So if somebody has sciatica, would it cause pain on both legs or just one of them?
Usually the side that's more impacted by the disc.
Okay, so one leg could be
Positive,
it's
almost
fine,
negative, right.
and then the other side
Right,
could be
right.
extreme.
And again, I would start that maneuver on the leg that's not symptomatic. If I have shooting pain down my right leg, I'm gonna examine the left one first.
Okay.
And this is what it feels like, and then the other one that's involved is different.
Mm.
and it says if they have sharp pain radiating from the back down the leg in an L5 or
S1.
S1 distribution, radicular pain, suggests tension or compression of the nerve roots, often caused by a herniated lumbar disc.
Right.
And dorsiflexion would increase the pain in that.
Because it stretches the nerve even more.
Okay. Increased pain in the affected leg when the opposite leg is raised strongly confirms radicular pain and constitutes a positive cross straight leg raising sign.
Which is why you would raise first and then dorsiflex. You
Right.
don't want them to dorsiflex and then.
Right.
Then there's the sacroiliac joint maneuver, known as Patrick's test. You place the lateral aspect of the heel on the opposite knee, move the flexed knee downward toward the table.
So this
Gently.
again is passive. So I would do this, okay, I'm gonna lift your leg, flex your hip, do this, twist it side to side, come back, then flex, rest your knee, rest your heel on your knee, and rest it this way and push this down a little bit. And if this hurts in the sacroiliac region, that suggests sacroiliacus. That's not a range of motion test, but if you're doing things in a fluid way, you would do it then.
Yeah, so you assess the pain, assess for pain in the sacroiliac joint.
Right.
area and
Low
perform this
back,
test on
up
each
here.
side. Evaluating knee swelling, allotment for floating patella. Firmly grasp the thigh just above the patella with one hand, thus forcing fluid out of the suprapatellar pouch into the space between the patella and the femur.
So that's, again, I'm gonna take your leg back to the middle here. I'm gonna grab it here and below and kind of squish and then
With the fingers
press
of the
down
other
on the
hand?
patella.
Yeah.
And if there's fluid, you feel the patella bouncing, which I don't.
This says
And
feel for
now-
palpable tap.
Yeah, if you tap the,
Yeah,
Because you'd be able to feel the patella hit the
yes.
femur.
Yeah, yes, as you push down, you feel it tapping the other side.
And then, so if someone had a positive bulge sign,
You would expect that you would be able to pull out the patella.
does it?
Although sometimes the bulge, there's a little bit of fluid, but not necessarily enough to bounce the patella. And sometimes there's so much fluid that you can't do a bulge sign, but you might be able to pull out the patella.
And
If
it
you're,
says
yeah,
allotment is a
because-
less sensitive test than the procedure to detect
Yeah.
a bulge sign,
yeah,
but useful when larger amounts of fluid are present.
at least we have-
Evaluating ligament instability.
this is new.
This is the drawer test. Oh, yeah.
Yeah, this is new.
What? We got a new thing. Have the patient lie supine with knees flexed to 90 degrees and feet flat on the table. Place both hands on the lower leg with the thumbs on the ridge of the anterior tibia, just distal to the tibial tuberosity.
That's okay, it's as far out as it goes. So here you're supporting the knee. Okay, keep going.
Draw the tibia forward, forcing the tibia to slide on the femur. Then push the tibia backward, anterior or posterior movement of the knee. The 5 millimeter in either direction is an unexpected finding and
Right.
it suggests instability or even a tear of the anterior or posterior cruciate ligament.
Go ahead.
And so, if you can push my tibia down, that indicates a tear of the anterior,
Yes,
which is the opposite,
yeah, opposite,
because it's giving when
Right.
it shouldn't.
right. So you're supporting here and then just trying to pull back and forth and I get nothing, which is fine.
And what would be happening?
So if you can slide it forward a lot, that suggests the posterior ligament's torn.
Okay.
If you can push it back, it suggests the
And back
anterior.
it goes this way and this way.
Yes,
Okay.
yes. Relax. Make sense?
I think it's something we need to feel.
Yeah, but you're probably not going to.
Wait, if it pushes then it's anterior.
Right, if you pull it, it's
Pull it
posterior,
and
right. Unless, again, I'm not sure if people who are very flexible, so are ligamentous laxity people, the hyperextensible people, they might have a little bit of that. In fact, they probably do, because these are also people who stand, they lock their knees back, you know, they hyperextend at elbows.
I tend to be hyper flexible. I don't know so much about the knees, but I have had knee problems because I have do you want to try and demonstrate on me and see if it looks like anything? I don't know. All right. I mean, I'm just willing to give it a try if that was helpful to anybody.
That concludes it, but I would like to feel it. 'Cause if I can feel what you were doing, then I know what I'm looking for. You know what I mean?
Do you mind if Kristen demonstrates on you?
Nope.
Okay.
go for it.
No, I suggested me feeling
you wanna
somebody
be-
doing
You want to be the patient?
David, I'll do it too.
Okay.
So, here?
Yeah. And then you just try to pull the tibia.
Because on meaty, you gotta make sure you're actually getting the bone. But,
Oh, God,
like,
I can't.
pulling the-
My hands aren't big enough to get to find your bone. No, nothing's moving.
Do you, well, I have do you wanna try on my leg though? I'm just wondering if it'd be more
Sure.
helpful to
Okay.
you. I'm happy to. You're an excellent patient, but I just.
Yes, you are.
Maybe there would be a
And
little
you
bit more
pass.
refining that would actually be helpful to you. Alright. So, does it matter if my shoes are on?
No.
I'll do this one.
Drape real quick, just since I'm on camera.
That too.
Smile.
So, tibial tuberosity, and then you wanna try to fold forward, here. Tibial tuberosity.
Am I in the same place she's in?
It needs to be, it looks like it needs to be a little bit
A
lower.
bit lower.
Yeah, you're,
Your
lower.
thumb needs to be a little
Oh,
bit
down
lower.
yeah,
here.
you're on the outside, yeah.
Yeah. Also, like literally grabbing
Am
the
I
top of the
pulling this
tibia
part
Yeah,
or am I
and
moving
pulling
something
forward.
here?
No, you wanna be pulling, imagine pulling this
The
part
whole
of her leg.
bone?
Yeah,
Because if this is my femur and this is my tibia, you're moving it like this.
Yes.
But you shouldn't be able to.
correct.
Oh, okay, okay,
Correct.
that makes sense. Yeah, it's not moving.
I have,
I'm not that
I
flexible.
have a question, I'm sorry, I'm asking too many questions about the
No, you're fine.
internal external rotation of the hip. But sometimes student would, instead of like, so, you know, at the 90-degree angle.
Yeah.
And then instead of moving the foot, they would push the knee in and knee out. Does that make sense?
That's adduction, abduction.
So instead of moving the foot,
Do you want
stabilize
to demonstrate
here.
on me what they
Yes.
would do?
Oh, yeah,
So,
So we were kind of doing the diaper drape.
Yeah.
yeah,
So, the leg here.
right,
This is what we are
that's
teaching.
what we wanna do, right.
But sometimes student would do this.
No, we don't want them to do
No.
that.
This doesn't do
No.
anything for internal external rotation.
Well, it kinda does, but it's
It's a
combining a
combination.
couple of maneuvers.
Doing both,
Yeah, it's not isolating as much
Yeah.
as the other maneuver does the hip.
Okay,
We did a 90-degree flagpole.
right.
Yeah. The other thing that that you might have noticed, or, well, that I should make explicit is I always examine from the patient's right side. It's an old O'Slary and Hopkins or whatever it is, it's always from the right. Although I was horrified to see one of the exam rooms at Bayview set up so that it would be on the
You
patient's
can't
left.
do it.
And I
Awkward,
can't.
yeah.
If you have a teeny student and a huge patient, then they may have to go side to side for some maneuvers, but
Mhm.
typically,
Typically, you can do
you
everything.
want them to do everything from the patient's right side.
That's
And
true,
and
cause
when
I'm
they ask-
small and I sometimes have to go from side
Yeah.
to side.
And when they ask why from the right, I always tell them there are two reasons. There's a practical reason that if every provider looks at the patient with the same angle, when you discuss them in the hall, you're seeing the same thing. And then there's a real reason. The real reason over in the Phipps building is a painting of Dr. Hostler doing it from the right.
Yeah, that's the way it's
It's
done.
tradition.
But are there, well, when we've done this with other faculty, occasionally there are some good reasons to do it from the right for
Yeah.
diagnostic reasons. With the musculoskeletal exam, is there any particular reason to do
No.
it from the right? Or is it okay?
No.
All right.
And often, a lot of the maneuvers I do from the front of the patient,
Mhm.
hands are upper sternum,
Well,
but,
and you said like doing it from the foot of the bed.
Yeah.
Yeah.
Sure.
but typically, if you have the patient supine, it's from this side. I've done it from but it just feels wrong, it's all wrong.
Probably the only one that you really need to do from the right would be if you're trying to palpate the spleen. Cause you
Yeah.
have to lean over and go
Yeah,
like
lean
this.
over, but-
Otherwise you could do it from the left,
Somebody-
but tradition is the right.
One of the videos does it from the left. I
Yeah,
forget
there is
whose it
one.
I'm trying to remember whose it is. It might be GI, but
I think there is
GI
one.
for the liver, I can't remember why, but anyway, but I was taught to do it from the right. Anyway, so, questions?
Yes.
Okay.
The drop arm test.
Mhm.
So if the patient can raise the arm here, but taps and drops, that's positive.
Correct.
If patient cannot lift it up here,
It's also kind of
that's also
positive.
positive.
Right.
Okay.
Right.
So
Either way.
here, would you grade that, like, you know, if you can like raise it up here or tap and,
Well, I might describe it. I might say
Okay.
patient can elevate arm but dropped to slight tap.
Is one worse than the other?
So if you can do this, it suggests a little more intact,
More strength?
yeah. If you can't do it at all,
then it's a complete. But there's no
Is there a difference
numbers.
on that, whether your arm is supinated or pronated? Probably not.
it's like John McCain couldn't get his shoulders up
Right.
because they were broken so many times, right?
Mhm.
If you notice how he moves through
Right.
many, many things. And I heard yesterday, he was with somebody years ago, and somebody had to bend over and brush his hair because he couldn't reach to brush
Yeah,
his own hair.
he can't comb his own hair.
Yeah. Anyway,
Wow.
Couldn't.
but you notice, I mean, other people, if you pay attention to this kind of limited shoulder, there's a lot of people that can't.
Yeah, my mom had rotator cuff problems and she had to stop, painting restoration was what she did.
Oh.
Antique oil paintings.
Yeah, oh my.
And she just couldn't,
Yeah.
couldn't do it. It was just too painful.
Good.
Yeah, I strained my rotator cuff and it took
Can't
over a
take it,
year.
you went
Thank you.
I have a question for you. I've been having this thing where when I bend down to do something, like
Mhm.
even weeding in a garden, and then I go up, it's like my hip pops and this pain shoots through right here, and I'm like, is my hip out of alignment? What is going on with this? It's kind of a new thing in the last maybe
A
6
little
months.
nerve twinge, little catch.
Maybe, it's like a pop, almost like a pop.
Yeah, little catch.
Should it take good notes?
So you think that's just like a nerve popping over or something?
Yeah.
So something's out of alignment maybe.
Maybe, yeah.
Yeah, I went to the
You don't
chiropractor
teach us that.
2 days ago.
Yeah.
And I don't know, maybe I should have him work on my hip a little while. I feel like I almost need an x-ray of it right then. I wanna know where it is, what's going on here.
You have questions?
What you're describing is more soft tissue, it wouldn't, I think.
Really?
Yeah, it would probably.
So maybe I should be doing stretching.
Yeah.
Yeah, okay, thank you.
Good question,
Question for
yeah.
you. For the shoulders, for the acromion process, when
Yeah.
you're just feeling for warmth, should there be warmth?
No,
So no, okay, just
no,
like
it should be, normal skin temperature,
is that mainly for anything?
anything,
If you're feeling warmth, then something's going on.
correct,
Okay,
correct.
thank you.
And you feel a difference.
Okay, comparing other sides.
Comparing other sides,
What
side
if
to
a
side.
person is hot all over?
Then
That's just like-
it's still different.
Yeah.
You feel a difference in
Oh.
it.
Okay.
Basically looking for asymmetry.
Yeah. Hi. You look different.
Look different with your
recognize
clothes
your-
on.
Yeah, you gotta be careful where you say those things.
Did we have any other questions?
Well, we did mention that typo. Did you hear that, Rose?
Oh, with the back, it's supposed to
In
be
the
right side.
lumbosacral spine range of motion, number 12.
Yeah, it's funny, that was the same as last year, nobody caught it last year, so,
Forward and back,
good job,
should be
Kristen.
side to side. She caught it. She's like, wait a minute.
Yeah,
I
why
don't
does it say
have
forward and backward, because that's a different maneuver,
Yeah,
that's,
forward,
that's
forward and
back.
back would be this.
It's- it's flexion extension.
It has to be side to
So
side.
Side to side.
Alright, well, I will definitely change it, the PETA notes, of course, this is already in print
Of
in the
course.
syllabus,
Right,
but
right.
I'll make a note for Rob for next
Mhm.
week. Although maybe he can correct it for what they post on Blackboard for the students, depending on what they actually look at more,
Mhm.
Let's see. I know, it's all changing, my son's starting college today, and I said, well,
Oh.
you have
Oh my
you have a
gosh.
credit, we actually got a little extra financially, like, we have a credit at the bookstore, I'm like, I don't know if we're even gonna have books, cause so much is online.
Oh, yeah?
Oh, no.
I don't know, we'll find out.
I don't know.
Anyway, so, yeah, I'll make some adjustments on this, and when I make these adjustments, do you want me to email you a copy?
That'd be great,
Okay,
sure, be
I'll
great.
do that. What I tend to do is I sort of make the PETA notes with the little corrections, but also some of your extra notes for the PETA's taxes training notes. Okay. Yeah, I mean, there's not too many to do with this, cause this is pretty thorough the way it is. but it's nice, I didn't realize when I first looked through this that we had an extra maneuver.
Yes.
How exciting.
Rob said we seem to have space, usually wants me to cut things out. Okay.
That's something.
Wow, how exciting.
Good, even though it's gonna be hard to demonstrate, and I'm sure we're not gonna find anything with the door, even if we get there, but that's okay.
It's something new to learn, I think
Yes.
people like that.
Do you have any
Good.
PETAs or SPs with like Ehlers-Danlos or anything?
Ah.
With like EDS, Ehlers-Danlos syndrome, or like
Not that I know of.
hypermobility?
Not that I know of. Some of the students always have a little bit, but not,
Sure.
you know, they can do. And I always, so if I'm, yeah, yes,
Like that?
like that. No, like this, look at her
What are
sideways.
you doing? Oh, that.
Like
What is
my,
that?
my joints are
Yeah.
weird.
Oh, yeah,
you're-
you're very.
wow.
That's it,
Whoa.
that's it.
Mine's a
I was
little
told
bit,
I was
hers is
flexible
like
like
a
that.
curve.
So if we find that,
Uh-huh.
as I said, I reassure the students that it doesn't lead to anything nasty. And I show them that, you know, I can, this is as far as I can go here, that's not bad. But these guys, that's all I got,
Yeah.
you know, I mean,
Mine's
that's it. And
Oh, okay.
so you are very
Oh, wow.
flexible, it's kind of a blend.
A little
So,
bit.
and
Just
think
my
of the,
fingers.
Really?
Oh, okay.
some of the dancers that, you know, the
Yeah.
ballerina, you know, that, or the gymnasts, the Cirque du Soleil kind of people who can sort of really touch their elbow to their ankle. sort of
Oh,
thing,
oh.
you know, or
There was
contortionists,
there was a
you know.
video recently of a girl that was standing
I
on
made
her
that up.
hands and brought her feet around and with her toes picked up a pair of glasses off the ground and put them on.
Ah, wow.
Yeah.
That's
That's
beyond
a little too
flexibility.
flexible.
And I was gonna say, that
It's
was
also some
scary.
good fine
Yeah,
motor
those
skills
guys,
with the
yeah.
toes, too.
Yeah,
Yeah.
yes,
I wonder, like, if they lose their mobility, it'll still be like more flexible than
yes,
most
yes,
people.
they'll still be normal.
Well, you know, what the anthropologists are now saying with the advent of the smartphone, that in another 100 years, if we keep going, we're gonna have very dexterous thumbs, unusable fingers, and we won't be able to talk.
I would agree with that.
Very true, very, very true.
Thank you.
We already
so
can't,
much.
Thank you all.
we already can't write anymore.
Right, I mean,
Yeah, there-
And how often do you go, we were somewhere, and, you know, people were at dinner,
and they're all sitting looking at
They're
their
all
look
phone.
at their phone, they're not
Yeah.
talking to each other.
Isn't that fun?
Oh, it's
You're
awful.
right. I don't have that much to say. A couple of years ago, we were driving to New York, and we were in horrible traffic. And there was a guy on his cell phone, and you know, when you're in traffic, you know that you're sort of playing tag with the same cars going and on and back and forth. It was about an hour, he was still on his phone.
Wow. Kind of multitask.
All right, well, thank you
You're
again.
welcome, thank you all for
Appreciate it.
doing all of this, we really appreciate it, and the students really appreciate it, there is nothing like working with you all, so. Thank you.
Thank you, doctor.
You're welcome.
Oh,
My
wait,
pleasure.
were we gonna have him demonstrate his?
Oh,
We
I don't
can
know
do
if
this
it's-
on our own
I don't know if
time.
it's